Morning, I'm Teoh, specialist in obstetrics and fertility care. In Perth, it is Sunday morning and it's actually raining pretty heavily. I came to the hospital pretty early this morning to review a patient who was worried about her pregnancy at 29 weeks, and she's totally fine. She's gone home, and I have another patient coming to see me later on. She's coming in about an hour's time. Early pregnancy, worried about pregnancy. Hopefully everything's fine. The last video I've done was in April, so about almost 2 months ago. Has been really busy. As you know, I was busy writing a chapter. I've been busy writing a chapter, and it's been published finally. So I'm back to do a few videos, and clinic actually is really busy. There's a bit of people saying COVID baby boom, and also people trying to get pregnant. So we have been pretty flat out. My secretary, as you know, Natasha, is working really hard to make sure all my patients are well looked after, which I really appreciate her help. To say thank you, actually got her little gift. I will leave it here. Hopefully when she comes back tomorrow or Tuesday, then she'll get a little surprise. Hopefully she likes it. Now, today I'm going to talk a little bit about prevention of OHSS, Ovarian Hyperstimulation Syndrome, which is one of the most serious complications, potentially one of the most serious complications in IVF. So essentially in IVF, we aim to get more eggs. There are different ways of stimulation. You try to get a good number of eggs, typically in Australia. And if, of course, the patients are able, typically I want to get anything above 7 or 8 eggs. I think that'll be a good number for the embryologists to work on, again, when patients are able to produce a good number and good quality as well. Now, quality is more important than quantity for eggs. Of course, both. If you have both, that would be the best. But if you ask me to choose one, I choose quality as opposed to quantity. Now, when specialists and doctors like myself, when we see patients, let's say, look, we do all the due diligence in terms of investigation and everything, make sure there's no other factors we need to treat for their fertility before we decide to say, okay, IVF is the best treatment for you, for the couple or for the patient, for the woman. So decide to go for IVF. Usually we have to decide what dose we're going to use in terms of stimulation to make the ovaries produce a bit more eggs for us to work on. And basically the most important things will be the body weight that we know, and the AMH, or the egg count, in a way, from antral follicle count when you do ultrasound scan. We want to predict, essentially want to predict how would the ovaries respond to our stimulation. So we decide a dose of drug. We say usually, the stimulation drugs will be FSH or with LH as well. The decision on the dose of drugs very much based on experience of the specialists and doctors, and also from research, and research has been done to decide what dose would be best for patients. So often it's a combination of those two. Age is important as well, affecting the way the ovaries respond, but age, if you compare to body weight and ovarian reserve, is not the most important response in terms of the ovarian response, how many eggs you're going to get if you already have the body weight and also the ovarian reserve. Now, age is the most important factor affecting the success of IVF, and age can affect, for example, ovarian reserve as well. But in terms of dosage, age is not as important as the ovarian reserve tests and the body weight. Now, I'm not going to go into the list of the FSH or LH we use because there are different companies with different drugs, and we usually choose one based on our experience and also what we think is best for our patients. Now, at times, usually I describe to my patients it's like throwing a dart. You want to hit the bullseye. So, you get very experienced, you train. So we thought, okay, this is the dose I'm going to use. It should be the best dose for my patient. However, even patients with the same character, for example, if you have a patient walk in, has got the same, she has got the same age, body weight, and ovarian reserve test as compared to the last patient that you see with exactly the same characters. If you give them the same dose, same drugs, they may actually respond differently. So we are not human, and I suppose living things, we are not absolutely the same. So even different people with same characters, you may have different ovarian response to the drugs for IVF. Even for the same patients, let's say sometimes within a few months, couple of months, 2-3 months, you give same dose of drugs for IVF for them, they go through a second cycle. The response can be quite different at times. I've got patients, one cycle got more than 10 eggs, and then one cycle less than 5 eggs. So with the same drugs. So perhaps you got a better month and you got not so good month. In terms of ovarian response to IVF drugs. So come back to ovarian hyperstimulation. Sometimes, you initially you thought, look, this is the best dose for our patient. They carefully planned, and patients go on to start the IVF journey. And after a week or so before the egg collection, you notice the hormones quite high, the number of follicles, the one hopefully with lots of eggs inside in the ovaries. There are quite many of them, and the ovaries get quite big. You thought, okay, this is potentially going to be hyperstimulation. Now today my focus is going to be on GnRH analog trigger. So for these patients, they have to be in antagonist cycles. For example, antagonist common drugs we use in those so-called antagonist cycle will be orgalutron or cetrotide. Those are the drugs that we use quite commonly to prevent ovulation in Australia. So those cycles usually are antagonist cycle. And let's say patients go through antagonist cycle. I notice before egg collection, there are loads of eggs, loads of hormones, and if I think, look, I'm really worried about hyperstimulation, then I will check their the FSH during baseline, either at the beginning of IVF cycle or sometimes they get it way before they even start the treatment. If they are not hypo, so-called hypopituitary, hypogonadotrophinism. So some patients have no hormones, FSH or LH, then you can't use the GnRH analog trigger. It's a bit technical, but it is a decision doctors made. What I'm trying to say is if you're careful and you use GnRH analog trigger, commonly in Australia we use either lucrin or decapeptyl for trigger. You switch the usual trigger for ovulation or to mature the eggs will be Ovidrel or Preganil. Those are the two common brands we use in Australia. But if you're worried about hyperstimulation, for certain patients fulfill certain criteria, which I've mentioned, antagonist cycle, not hypo, use lucrin or decapeptyl, then the risk of getting severe hyperstimulation is much, much lower. Now you have to be careful when you use lucrin or decapeptyl trigger, the GnRH analog trigger, then usually prepare to freeze all embryos. That means no embryos transfer in this cycle. Apart from sometimes you change your mind, you thought, look, actually it's not too bad. We may have to transfer, or we may be able to go for fresh transfer. Then when they come for egg collection, you give a baby dose of Ovidrel or Preganil, so you can kind of add back. Because if you don't give those, if you change your mind, you give lucrin trigger or decapeptyl trigger, as I mentioned, and then you go on, okay, let's do transfer, and without the HCG, a little bit to add on the baby dose, then you won't have a good support, which is very important, the lining, luteal phase support to support that lining and support the embryo. So if you give lucrin or decapeptyl, then you thought, okay, let's freeze all. But if you think you may do a fresh transfer a few days later, then you need to add back. When they come back for egg collection, usually a few days later, you might need to add a little bit of HCG. But when they add a little bit of HCG, then the risk of hyperstimulation increase again. So it is a bit technical, but what I'm trying to say, IVF has moved on. It's not 100% foolproof, but if you're really careful, that's a good way of preventing severe hyperstimulation. Not all cases, definitely not all cases, but many cases. That's all I'm going to say this time. So I'll see you again next time. Bye bye.